That's right. So many more tools at my disposal.
To help him with the
Breathing will give you a
Training
treat.
manager for the ICU.
You replicate that. That is not gonna help you get the noise. Then when he shoots up a booger on you, you'd be like, here, look, we like the girl.
Thank you.
I don't know. You're not in my favorite.
Is that your melted candy?
Josh is so.
I was gonna say, it's very deformed.
And they're-
He would not stop suctioning.
But then the
Like, okay,
family wanted
it
him
looked like it
to-
was completely gooey. Make sure I'll take a slurp. No, I'm kidding. I'm kidding.
I was just saying, then they wanted him to plug it so they could talk to him.
That's really crazy.
Is that how that works?
Did they put a scopolamine patch on?
My patient, finally, after I've been sucking her 7 times.
She's like a postpartum versus been there for months.
We use scopolamine, so we used to use scopolamine during labor, and it can have some weird side effects for some people. Makes some little, my husband cannot take scopolamine, like he had a stomach virus and had some patches left. I was like, just put a scopolamine patch, and he was like belligerent and throwing things, and I was like,
Well, Josh didn't have to worry about that.
and I called his dad, he's a PA, and I'm like, I need to get the patch off of him, but I can't get close enough to him, he's crazy right now. Yeah. It's the reason that women used to howl at the moon during labor, so scopolamine is like a drug, but it doesn't work for everybody.
She's like, I sat
How
on
did
it.
you end up using her?
I finally he calmed down enough and I ripped it off his ear and I was like, just go outside, just go do something, I don't know. And he was fine. Very out of character for him, he's usually pretty laid back.
That's usually the one.
That's always the ones you gotta be careful of. Alright, any questions so far on our postpartum assessment? So now we're gonna pick back up with Reese and use her as our patient to apply some of this information that we just.
Oh, she's geriatric.
Yeah, she's our little geriatric lady. Okay, so this was Reese, she's the one that we took care of last week, she's the gestational diabetic. Just to kind of refresh your memory, she did labor, push for a couple hours, had a 9-pound, 3-ounce baby girl with a moderate shoulder dystocia. She had a 3rd-degree laceration with repair, and you are picking back up with her immediately following delivery. Okay? All right, tell me what you think about her vital signs. Any red flags or things that you go, might need to keep that in mind.
Is the EBL estimated blood loss? So that's a concern.
It really should have been QBL, like quantitative blood loss, but yes.
Well, that is over.
But she's older, isn't she? She's had multiple kids.
She's had one other child, yeah.
In her respiration.
Oh, well, how many pounds was the baby?
9'3".
Oh, well, it's a new baby, so no.
I would say no.
I don't see anything on there that is just blazing that, oh my gosh, I need to do something about right now. I will tell you what gives me a little pause, is her pulse being slightly elevated, but she did just push for 2 hours, so we'll give her some credit for that, but I'm gonna keep an eye on it. And we do know that her blood loss going into this postpartum period is already a little bit more than we would expect. Typically speaking, pregnant patients or delivered patients can tolerate blood loss until they can't. Like it's like, they truck along and everything's fine, and then all of a sudden it's not. And somewhere between usually that 1,200 to 1,500 milliliter blood loss is where we typically see them start to become pretty symptomatic. So we're not there yet, but it is a little bit more than we would expect. She is a Gravida 3 Para 2 now. She was a Para 1, but now she's delivered, so that changed her Para. What are some additional assessments that you would want to do for her?
We have to check that tear.
Okay, so we're gonna check those 3 main things, right? The fundus, the perineum, and the bleeding. There we go. Our fundal assessment shows that she is 2 centimeters above the umbilicus. She is midline but boggy. Her perineal assessment shows that her episiotomy is well approximated. There's some bruising and swelling that was already there, and she has a large amount of rubor with clots. Massage the fundus. If you learn nothing else from me, you gotta learn to massage the fundus, okay? So if you have heavy bleeding with a boggy uterus, the 2 actions that you're gonna take are to massage the fundus and make sure the oxytocin is running. Remember, it should be running at a bolus rate. Maybe your IV came out, maybe it's cramped, maybe it's in the bend of her arm and it's not working. So you're gonna confirm that her oxytocin is running and you're gonna massage the fundus. Okay? Let's talk about something else that could happen. What if you found that your fundus was firm, but when you pulled back the cover, there's a constant trickle of blood? That's a cervical laceration. So boggy fundus with heavy bleeding, massage the fundus. Firm fundus with a constant trickle is usually a cervical laceration. And the problem is, no matter what I do as the nurse, it's not gonna fix the cervical laceration. So that would be an automatic call to the physician if you suspect that the cervix is torn. Cervix is very vascular, and you can lose a lot of blood from a cervical laceration, okay? All right, so we're gonna massage her fundus. We did confirm that her oxytocin is running, and we are going to do those interventions. We did those. Despite our interventions, her uterus remains boggy with a moderate to large amount of rubra, no clots right now. Normal or abnormal?
Abnormal.
Still abnormal. What do I wanna do about it now?
I'm just gonna call it lead.
We are gonna get further orders. We're gonna have to call the MD. So let's talk about what we would need to assess prior to calling the MD. Because when you call, you're gonna use what technique to conversate with him or her? SBAR. And one of the parts of that is, what is my assessment, right? So we are gonna go ahead and calculate what our blood loss is now. So let me explain how we do this. So if we're doing quantitative blood loss, which is what we would be doing, and we are measuring it post-delivery. So initially, the physician will tell you how much was lost at delivery based on what was in the drape. That's where that 550 came from. Anything else outside of that, we're gonna weigh. So we're gonna look at the dry weights, which you do not have to memorize. This will be given to you on the test because every hospital has different items that they use and they weigh different amounts. So you will have a list of dry weights. So essentially what you're gonna do is you're gonna look at what you're weighing. So in her case, she saturated a peri pad and had a large area on the pink pad. We need to figure out how much those items would weigh if they did not have any blood on them, right? So if we add 75 and 355, what do you get?
430.
430. So that is the dry weight. No blood on those items is 430. So what you would then do is you would weigh the items that have blood on them. And in her case, they weighed 1192 grams. And you're gonna subtract the dry weight from that. So you're gonna take the 1192, you're gonna subtract the 430, and you're gonna get 762. So the blood loss for this specific bleeding episode was 762 milliliters. Okay? Be careful how the question asks it. If it says, what is the blood loss for this bleeding episode, the answer is 762. If it says, what is the total blood loss since delivery, which is probably what the physician's gonna wanna know, you would add whatever it was before. So it's 550 plus the 762. So our new blood loss is what? 1312. Okay? Now are we in trouble? Yes, because now we're kinda at that tipping point. So her blood loss is 1,312. We talked about cervical laceration. What is the medical term for what's causing a boggy uterus? Kind of. There's another term for it. Uterine atony. So if you have a boggy uterus, the other way that we could call that would be uterine atony. It's not contracted down. So because she's boggy, we think this is related to her uterus is just not clamping down properly. Most of your early postpartum hemorrhages are caused from uterine atony. The uterus itself is just tired and it is not clamping it down like it's supposed to. So we call the physician and we give him the most excellent SBAR assessment that we can, and these are the orders that we get back. He does remain in the department. He says, go ahead and make sure that the Pitocin is going, which we'd already done, and you can hang a second bag if you need to. Go ahead and give Cytotec and Repeatistat H&H. Okay? All right, Pitocin we've already talked about. Biggest side effect that we see of Pitocin after we deliver a baby is going to be that swelling or that water intoxication. They're going to retain fluid. Why are we doing a repeat H&H? Because we now need to know what our new baseline is. Where are we hanging out right now? And then the other medication, one of the second line drugs that you'll see commonly used is Cytotec. Okay? Cytotec is the trade name, so you're gonna know it as misoprostol, which is what you will see on the test. label, what do you see with the big red circle and X there? If you look up this drug, it's gonna be listed as a category X for pregnancy, but let me explain. If you were to give this drug early in pregnancy, it could cause you to miscarriage. That is the reason it's listed as a category X. It is one of the common drugs that's used for abortion, given in oral form, so it can be used for that as well. We can also use it for induction of labor at a very small dose, or we can use it for postpartum hemorrhage. It is cheap, it's efficient, it works well. We use a lot of cytotec for a lot of different reasons, okay? The dosing is completely different, and I don't expect that y'all need to know the induction dose of cytotec, but just to give you a frame of reference, if we're using cytotec for induction, we usually give 25 to 50 micrograms. If we're using it for postpartum hemorrhage, it's usually 800 to 1,000 micrograms, so completely different dosing, okay? If we're doing it for induction, we typically put it intravaginally. If we're doing it for postpartum hemorrhage, we always do rectally. Why? Yeah, if you push it into their vaginal area, then if they're having blood loss, it's just gonna wash it right back out. It's not gonna come in contact with these membranes. So for postpartum hemorrhage, we're gonna give it rectally, okay? Tell me, if I'm giving 800 micrograms, how many tablets am I gonna give if that's my drug level? 4. So you would literally put 4 tablets in your rectum. Just make sure it comes in contact with this membrane. We give it rectally because it works quicker that way.
What if she had a,
3rd or 4th degree laceration, push it to the back, not the front side where the incision is. Yep, somebody asked that earlier.
And it's also like transdermal, like you're not supposed to touch it, they give you heartburn, right?
I mean, I wouldn't advise it. I don't think much is gonna absorb through your skin if I'm being honest. But if it was crushed or something, then it could potentially absorb through your skin for sure. Everybody good with that?
Not that I think I'll be anytime soon.
Alright, tell me what risk factors Reese had for having a postpartum hemorrhage. What are some risk factors we talked about last week?
Diabetic.
Okay, she had a big baby, which was consequence of diabetes. Do what? She was elderly, which is not in and of itself a reason, but it did predispose her for some other stuff. So big babies are gonna be risk factors for postpartum hemorrhage. Long labors with oxytocin, which she also had. She also had a shoulder dystocia, so any type of birth trauma that causes more instrumentation or things to be done to the vaginal area is gonna increase risk. She had a laceration that was significant. The other one that we mentioned last week, which doesn't apply to her, but just FYI, would be magnesium sulfate. If they're on magnesium during labor, they're gonna be higher risk for a hemorrhage. So she definitely has some issues that predisposed her to have this lovely hemorrhage. Cytotec is given. These are your repeat labs, and those are your repeat vital signs. Okay. Does the H&H reflect that she had a hemorrhage?
Yes.
Are we to the point where we are dangerously low on our H&H currently? We are lower than we were. I'm not happy about the hemorrhage, but I am not thinking that we're gonna have to transfuse at this point, okay? What is your kind of cutoff? When do we typically transfuse med-surg patients? Below 7, which is insane to me. So we're gonna say below 7 and or symptomatic. So with these patients, a lot of times they will become symptomatic because they lost the blood so fast, they didn't lose it slowly, and so they may be symptomatic at a slightly higher H&H level. Alright, what are our vital signs telling us? She's lost blood and she's trying to compensate for it, right? My blood pressure has dropped slightly, not dangerously low, but it has dropped slightly, and my pulse has gone up. So now that pulse is significant, because the first thing that's gonna happen when you lose blood is your pulse is gonna go up, try to compensate, and then your blood pressure is gonna start to drop. Now, when we talk about interventions, especially for your postpartum hemorrhage and things that we do, you have to be able to determine if your interventions were effective or ineffective, right? Now, based on what we see now, are they currently effective?
No.
Okay, tell me what would tell me that they are effective. What would you expect to see in that patient if the cytotec is working? Not a trick question, just think it through. Pulse will come back down to normal.
And blood pressure.
Blood pressure will be at baseline. What about her mental status? What would she feel like if she was shocky or didn't, like, had lost a bit of blood. I don't feel good, I'm dizzy, I feel like I'm gonna pass out, she could have some nausea. She could also have change in level of consciousness, right? What about her assessment that we did? What should return? Our uterus should go from being foggy to being firm, and above the umbilicus to being at or below the umbilicus, and it needs to be midline, right? And my lochia should do what? It should decrease. So if we were large with clots, and she's now moderate, better, right? If she was large with clots and now we're copious, we're not better. And if we're not better, what would we do? Call the doctor back and say, hey, you wanna come back and see us a little bit? What else do you want me to do? Here's what we got going on, right? So you always have to see if they're effective, and if they're not effective, then that's gonna warrant further intervention. We gotta do something else, right? Yes.
Alright, stupid question, but this messes me up. So for like white blood cells, it says 10.
It's 10,000.
Okay, but it doesn't say that
It
anywhere on
doesn't.
that chart, and that messed me up on a test question. But seriously though, because they do that and they don't tell you it's
Same thing for your
thousands.
platelets. So your label on the side, so if we give you values, hopefully it will have the label which has the exponent and all that, but you can assume that it's to the thousands.
That it's never actually gonna be 200.
Correct. So like if it was a white count that was really low, it would be like 1, not 10.
Okay.
That makes
Well,
sense.
I feel like it needs the key.
It does, yes.
And there was one like that on one of the
Yeah,
Hassies.
this one doesn't, but I have tried to go back into mine and make sure that it has the legend on the side, but you can assume if it says 5, it means 5,000.
Okay.
Yep. And that's the question we can always answer on the test.
Oh, okay.
So you can, I will answer that. If you say, hey, is this really this, or is it 10,000? I will
Okay.
answer that. Okay. All right, any questions about the labs that we're seeing? So, yeah, she will probably need Rogaine as long as. If the baby's positive, yes, she will need a postpartum dose for sure. All right, so we go ahead and we reassess, and now her uterus she has more moderate bleeding. Are we okay with that? We were in March, now we're at moderate, we think we're heading in the right direction, we're gonna keep monitoring her really closely. So let's talk about some other drugs that we can see for postpartum hemorrhage. Because why not? Let's just cover them all at one time. Alright, this is called TXA, or tranexamic acid. We use it a good bit now in labor and delivery. It's not isolated to postpartum hemorrhage. You can also use this for post-surgical hemorrhage. But we do use it a lot in our postpartum patients. So, can be used to treat postpartum hemorrhage. It is more effective if it's given within 3 hours of delivery. And what we do know is that about 90% of the deaths that we see from postpartum hemorrhage occur within that first 4 hours. So this has been something we've added to our arsenal as a backup drug if we need it. The dose is usually 1 gram given as an IV piggyback over 10 minutes. You do need to monitor the patient for hypotension, although I have not typically seen that side effect, but it is one that you can see. So if our side effect was not effective, then this may be a drug that we may be given. So we've now mentioned oxytocin, we've mentioned Cytotec, we've mentioned TXA, and let's just go ahead and cover the other two. So on the right-hand side, you will see the oxytocin and the Cytotec that we've already talked about. There's 2 other drugs that you need to add to your list for the treatment of postpartum hemorrhage. They're not used as readily because there's some reasons we wouldn't give them, but they are in our lovely postpartum hemorrhage kits. So the third one down is Methergin. It is an IM injection. It is not given if the mom has hypertension or preeclampsia. The last one on that list is Hemabate. Hemabate is also an IM injection. We rarely use it, and the last few times that we have used it, we've used it in the operating room, and the surgeons actually placed it directly into the uterus, because the uterus is muscle. But it can be given as a regular IM injection. We do not give it if they have asthma, because it can cause bronchospasm.
Do we need to know the Methergin name, or we need to
No,
know
you need to know the other one.
methyl ergotamine?
Yeah, at least that one's close. And then the prostaglandin first line drugs are gonna be fundal massage with oxytocin, followed by one of the backup drugs, usually cytotec and TXA, and then if we need to, we would go on down to methogen and humate if needed. On the left-hand side, I just wanted you guys to be exposed to this. I do not expect that you memorize this key. If I were gonna ask you a question, I would give you this whole thing right here on the left-hand side. But this is what we do when they come in. So we do a postpartum hemorrhage risk scoring on admission to labor and delivery, prior to delivery, and then in the postpartum period. So we do 3 separate evaluations to see what risk they are. And so I could give you a test question and give you this, and give you a patient scenario, and you have to calculate, are they low, medium, or high risk? And what you would do for that, which is also at the bottom. Okay? I think interpreting order sets and risk scoring and that kind of thing is very important, but I don't expect you to memorize the risk scoring. We don't memorize it, so why would I expect you to? But you do need to be able to interpret it if I gave it to you. Okay? Are any questions about any of that? Moving on. Alright, so it has now been 1 hour post-delivery, and Reese is wanting to ambulate to the bathroom. Okay? Did she, first of all, let's talk about safety. Did she have an epidural? She did. So let's just talk about any patient for an epidural if we're gonna get them up and ambulate them. What do we need to assess? Can they move their legs, right? So can they use their legs? So the first thing I ask them is to bend their knees, and do their legs feel normal? If they say yes, then we go to the next step, which is what? Let's sit on the side of the bed, right? Make sure they're not gonna get dizzy. Patients that have had babies will pass out on you. Usually the first 1 or 2 times they get up from the bed, so you need to always make sure you have a friend if you're going to get a patient up, because if they're gonna pass out, it usually happens in the first couple times up. So we let them sit on the side of the bed, and we let them dangle there. See if they're gonna get dizzy, recheck their vital signs, make sure everything's good, and then what is the third step? Let's just see if you can stand, right? And if she can bear weight on her legs, then we can go on to the next step. If she buckles when you stand her up, what happens? You put her back into bed, and she gets to use bedpan, right? If you can't get safe into the bathroom, you just can't go to the bathroom. Now, as long as she can bear weight and she feels pretty normal, we usually tell them to lock their knees, because there's still something about bending that knee, and they'll kind of buckle, and it's hard for them to straighten it, so they do this weird shuffle thing in the bathroom. Okay? You hold the pad in the front, I'll hold it in the back, and we shuffle to the bathroom. As long as they can safely go to the bathroom, do make sure that your patient is safe. If they're hemorrhaging and it's unsafe for them to ambulate, then we're gonna have to drain their bladder some other way, okay? So her uterus is deviated to the right, so we know she does have a full bladder, and she can't really feel her legs. So she's not getting up out of the bed. So how would I drain her bladder? You can try to put her on the bedpan, but if she can't feel her legs, chances are she probably still can't feel her bladder. So we tried that, bedpan didn't work. What am I gonna do next? Straight catheter and indwelling Foley. So depending on what's going on with the patient, she did have a 3rd-degree laceration, so we just called the doctor and said, do you want us to straight catheter or put a Foley in? He said, just put a Foley in and leave it, okay? So we would do that. Tell me what we think about her vital signs. They look better, right? That's probably her baseline. So everything in that looks better. What do we think about her fundal findings?
They're not great, but.
Okay.
better.
All right, what do we think is the likely culprit? Her full bladder. So a full bladder is gonna displace the uterus, it's gonna make her bleeding heavier. So I think once we empty her bladder and reevaluate, that will hopefully fix itself, okay? So empty her bladder, so we go ahead, because she's had that swelling, and she's had that 3rd degree, we're like, let's just go ahead and put Foley in. So we do place a Foley catheter, and we get some other orders from the doctor. Okay? So let's go through all of these. So he says, insert a Foley, leave it in place, let's just let her rest if we can get some of the swelling under control. Transfer her to postpartum in an hour if she remains stable. So most of your hospitals, that patient will stay pretty much one-on-one with their labor and delivery nurse for 2 hours after delivery to make sure they're stable before they go to the floor. Regular diet, which makes sense, right? She's had a baby, please feed her, because we probably have not done that in labor and delivery. Why would we do a CBC in the morning?
This year.
Okay, check for infection potentially. Definitely to relook at her RBC count and her H&H. Prenatal vitamin, how long do they take prenatal vitamins post-delivery? Usually 6 weeks if they're not breastfeeding, and then is the entire time they are breastfeeding. So if they are breastfeeding, they will just continue their prenatal vitamin. Because the reality is, if you're breastfeeding, that baby's gonna take what it needs, which means you need to retanking yourself up to make sure that you have enough on board, so you still continue that prenatal vitamin. What type of medication is Anaprox? Generic name for that is naproxen sodium. It's an NSAID, so it's basically prescription strength Aleve. Okay? NSAIDs are really good in that postpartum period. It helps with inflammation, it helps with swelling, but it also helps with pain, and you don't get the nasty side effect of causing sedation. So we use a lot of NSAIDs in that post-delivery period. We do usually also give them something stronger for pain should they need it. So in her case, she's getting Percocet, which is gonna be Tylenol mixed with a narcotic, that we usually give for severe pain. Activity is tolerated. Why are we offering her a Tdap vaccine? It's to protect the baby. So I think they usually get the pertussis vaccine around 2 to 3 months, but in that 2 to 3 month period, if they were to get pertussis, it could definitely be life-threatening for a newborn. So the new recommendation is that direct caregivers get a booster shot, so they get a Tdap vaccine. So moms, dads, or if grandparents are gonna be directly caring for the baby, then they would recommend them as well. MMR vaccine if needed, so what would indicate that there is a need for the MMR? What two findings? Non-immune and equivocal. Yep. Equivocal just means that, you might have some immunity, you might not, so it's gonna go ahead and boost you up. Rhodium if indicated, so mom does have a negative blood type. If baby is positive, then she will get a postpartum dose of rhodium within 72 hours. We're gonna give her a stool softener just for all the reasons that you can imagine, that you don't want them straining to have a bowel movement. And then they will have usually something on their order form for episiotomy pain/swelling. Epifoam is an option, Dermoplast is the other one, so I'll show you Dermoplast in just a little bit. It's like a spray, that one's used more commonly. So it is just to help with episiotomy or laceration pain and swelling, okay? Any questions about any of those orders? It is now an hour later, and these are your findings. I want you to tell me if you feel like she is stable to be transferred to postpartum based on these findings. Looks like her vital signs have stabilized, her fundus is now firm, midline and one below, which is what we want. Her rubric is small, no clots noted, her perineum is swollen. So you're gonna treat their perineum kind of like a sprained ankle. Ice for the first 24, then you can switch to heat. And she has a lot of swelling, so we wanna make sure we keep that ice pack in place, and then she also has that forward. So she is good to go. When we transfer her to the postpartum nurse, we're gonna have to give report. I was gonna make y'all do that, but I'm just gonna be nice. I'm gonna do it for you, you can tell me if I miss anything, because I probably will. Alright, so you're now the nurse that's receiving Reese, and you're receiving this lovely report, and let's see if we miss anything. So this is Reese, she's 36 years old, she had a vaginal delivery earlier today, she was 41 weeks. Her blood type is B negative, her RPR was non-reactive, all of her other prenatal labs were negative, and she has no known drug allergies. She is planning to breastfeed. Cord blood has been sent because she has a B negative blood type. She was GBS positive and treated ×6. Her rubella is non-immune. She has a number 18 gauge to her left wrist infusing Pitocin. That's her second bag of Pitocin. It's infusing at 125 milliliters per hour. She is a Gravida-3 parent 2 now. Her vital signs have been stable over the course of the last hour at 120s over 80s. Her pulse has been 80s to 90s. Her quantitative blood loss was 1,312 milliliters. She did receive Cytotec in postpartum. Her fundus is one below, firm and midline with no clots and a small amount of lochia. Her Foley is in place during the clear yellow urine. She had a 3rd degree laceration with repair. Her perineum is swollen and bruised, but is at baseline. Ice pack is in place on a regular diet. Current H&H is 9.2 and 28. Anything else? Great, there was something this morning. Okay. So it is now the next morning. She wants this catheter out. having some cramping when she breastfeeds. She is having problems getting the baby to latch properly. She has some perineal pain that she rates at 6 out of 10, but doesn't want to take anything to make her sedated because she is breastfeeding. And those are your morning labs.
H&H.
Okay, H&H went down a little bit. That's probably where she's gonna land. I don't think that's a huge drop, but that is where we're at now. Okay, white blood cells, let's talk about it. So in the postpartum period, unless there are other reasons to suspect that there's an infection, an isolated elevation of white count is normal. To the point that we typically don't even check it because we know it's gonna be abnormally high, okay? So what I always say is if you have an elevated white count and they're running a fever or they have purulent discharge, that's an infection. If you have an elevated white count and nothing else going on, that is a normal finding or an expected finding, okay? So I'm not too concerned about that white count if she's not running a fever and there's not anything else that tells me she has an infection. And we are gonna keep an eye on that H&H, and we think that's probably where she's gonna settle.
How long after would you expect the white count to be elevated?
We usually don't even check it, to be honest with you, but probably for the next 2 to 3 days, you're gonna see some elevation, but it should start to track back down.
So because the body's trying to heal.
Yeah, because it went through a trauma and the body's like, whoa, let me just send all the fighters down there because something's not right, right? So it's just more of that inflammatory response that we see from the delivery. Okay. All right, we're gonna assess her perineum, and so we do notice that she still has some swelling, which we expected, but it is better. Her fundus this morning is 2 below, firm and midline with a small amount of lochia. Are we okay with that? Okay. What do we wanna do about getting that Foley out? Who makes that decision? The doctor. So we call the doctor and he says, sure, just go ahead and get the Foley out. How long does she have after we take the Foley out before we need to be concerned if she can't void? Depends on who you ask, right? I'm gonna go 4 to 6 hours. Some hospitals will go up to 8, but for our patients, when we are hydrating them and keeping them hydrated, 4 to 6 hours is about the max. If they are 4 hours later and they have not voided, how can I check to see if her bladder's full? You can do a bladder scan, because that's gonna be a lot less invasive, okay? So we do need to make sure that she does void. What do we want to do about the fact that she is cramping when she breastfeeds? It's normal. Can we give her pain medication for it? We can, but she does need to know that that is normal. Especially because she's breastfeeding, it's gonna cause that natural release of oxytocin, it's gonna cause her to have some contractions. So it is normal, but we can give her something for it. What could we offer her for pain that would not give her that sedation? Yeah, she's got the naproxen, right? So we could give her an NSAID, so it helps with the pain relief, helps with the inflammation, but doesn't cause sedation. And then what are we gonna do about her having difficulty with latching? Teaching? And who can we get a consult for? Lactation consultant. All postpartum nurses and labor and delivery nurses can help with breastfeeding. It is not our passion. You know whose passion it is? The lactation consultant, who knows all the tricks and will take a spoon in there and manually express that mom if needed to get her over this hump. They are fantastic resources, so please use them. So if you have a mom, when you did that initial assessment and she had a flat nipple, lactation needs to be involved because they need to get shields and there's some techniques that they can use. If the baby's not latching properly or it's hurting a lot when the baby latches, then they're not latching properly. We need to get lactation involved because they know all the tricks and the holds and the different things that we can do, because breastfeeding does not come natural to everybody. I love those videos where the baby crawls up the mom's belly and latches onto the boob. That is not reality for probably the majority of patients. It is a job and it is a full-time job. So I always tell my moms, if you want to breastfeed, you gotta give it 2 weeks. 2 weeks of hard effort, and then at the end of that 2 weeks, if you wanna say, hey, I'm done, usually by 2 weeks, we can get all the kinks worked out, okay? But it is not always easy for everybody, just kind of keep that in mind. We will need to make sure that we count her voids for the first 3 voids, that is standard. So once the Foley's out or once they're delivered, we do 3 we check the amount for the first 3 voids. Once we have determined that that is adequate, then we are good to let them void on their own without measuring it, okay? Unless there's something else going on. Remember that? Moving on. Let's talk about some of the lovely things we do for perineal pains. Let's talk about perineal care in general. Every time we get our patient up or they get themselves up to go to the bathroom, they are gonna fill this lovely little water bottle right here with really warm water. and they're gonna clean their perineum from front to back. That's regardless if they have an episiotomy or laceration or not. If they do have an episiotomy or a laceration that has been repaired, they need to pat that area dry. I typically do it with like a bath ball versus toilet tissue. It's just think about toilet tissue, if it breaks off, it gets stuck to a suture, it's just like a little mini petri dish of just yuck, okay? So pat dry, make sure the area stays nice and clean, and you're always going to clean the area front to back. Always, 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 okay? For pain relief, we have several options. For the first 24, we're gonna do ice packs. After that, we can do heat. One of the ways that we do heat is something called a sitz bath, which is what this is. So you set the little pink part in the toilet, you fill the bag up with warm water, it lets warm water flow over the perineum from front to back, keeps the area nice and clean, and can help with pain relief. It is not medicated, so if you can't find your mom that had that 3rd-degree laceration, she's probably doing a sitz bath in the bathroom. Just knock and say, "You good?" Okay, because that usually is very comforting. The 2 medications that we typically use for perineal pain is gonna be the Dermoplast, which is the top right, that's a spray. And then the Epifoam, which is the top, which we don't use as much anymore, but it is a foam. I usually just put it directly on the perineal pad, so that when we put the pad on them, it comes in contact with the suture line, okay? If they have hemorrhoids, they get some lovely witch hazel. So if they are really having some issues, they're gonna have the Epifoam at the front, the witch hazel at the back, and everything's just gonna be tucked in there nice and neat. Witch hazel helps to constrict their hemorrhoids and help to prevent bleeding and to promote comfort. You can also see us use stool softeners like Colace or Donkey State to help prevent that force of stooling as well. Questions about any of the perineum?
Does any of that stuff have an antibiotic in it also, like a Bactroban or something like that?
No, so you just kind of watch it. The Dermoplast is more for pain control, the Epifoam is more for inflammation, but either one of them have an antibiotic component to it.
Do they have an insert for the toilet?
We usually just use like the Puritan hat, and just make sure it's in the right location, yeah. Sometimes they'll overshoot a little bit, but. Any questions about that? So she has an uneventful rest of her stay with us, and we're gonna do discharge. So a lot of your test questions come from that postpartum assessment, what's normal versus abnormal, what are you gonna do about it? The other big chunk comes from this slide right here, which is what education and complications do we need to monitor for? So, we'll start at the top. We know that our postpartum moms, pregnant moms and postpartum moms have an increased risk of clot formation. So we do need to teach them about DVT prevention. So we typically tell them to do what? Get up and move, right? So get up and walk around. So early ambulation is one of the key things that we do to prevent DVTs. But we do also need to educate them about signs and symptoms of a DVT, which was 113 content. But tell me what you're gonna see. How am I gonna teach my mom if she's got a DVT, what to expect? Unilateral, pain and swelling, redness to the cat, okay? So unilateral, red, angry, swollen leg, usually around the calf area. That would need to be reported to the healthcare provider. If for some reason this mom is not gonna be up and ambulating, what can we do to help mimic ambulation? The SED hose. Because it can move and become a PE, what are your signs and symptoms of a PE? Sudden onset of shortness of breath or chest pain. What's the other one? Sense of impending doom. If your postpartum mom tells you she feels like she's fixing to die, you better believe her. Because there's definitely some nasty things that can happen, but this is one of them. You will cover PEs later this semester, but that's all you need to know about it for right now. So you're gonna teach them how to prevent the DVT, the signs and symptoms of the DVT, and the signs and symptoms of a PE that they would need to call immediately for. Who do they call if they have sudden onset of shortness of breath and feel like they're fixing to die? The ambulance, not the office. Okay.
They better not call me the voicemail like that.
You would be surprised. It's kinda like those TikToks with the farmer who comes in with an ice chest. Did your wife send you? No. Okay, he's really sick, kind of thing. Sometimes you get weird calls. Alright, what are we gonna do to help improve that pelvic muscle tone? What is the exercise we do? Kegels. How do you teach a patient to do Kegels?
Stop and start their beat.
Yep, so while you're sitting there doing that pericare, stop your urine. That's a Kegel. Do it as often as you think about it. Every commercial break, do some Kegels. Okay? Is anybody gonna know you're doing Kegels? Maybe y'all could be doing Kegels right now. I wouldn't know. What are you doing? Do your Kegels. Alright, what about nutrition? What type of instructions are we gonna give about nutrition? Do they need to increase their calories? Increase by 300 to 500 if they're breastfeeding. They need to increase by 300 to 500. If they're not breastfeeding, they still need to eat a well-balanced diet. Okay. Talk a little bit about nutrition specifically for your breastfeeding moms. So they will increase their caloric intake, usually 300 to 500 calories from nutritional sources. We also tell our moms who are breastfeeding to limit caffeine because if it hypes you up, it may hype baby up. And if it makes you gassy, it's probably gonna make your newborn gassy. So if they notice that they're having a lot more gas in the newborn, they may need to adjust their diet to see if that will help. It's kind of funny now because we didn't used to do this, but now if you have moms that are pumping, they will usually label it if it's morning milk or afternoon milk, because if they had coffee in the morning, they wanna save that milk when the baby's supposed to be awake, because it will cross as breast milk. Alright, looking at breastfeeding versus non-breastfeeding. So if you have a non-breastfeeding mom, we're gonna tell them to wear a tight-fitting sports bra or to bind their breast with an ACE wrap. We're trying to keep their milk from coming in as much as we can. We're also gonna teach our non-breastfeeding moms when they shower, they need to shower with their back toward the warm jets of water, because if they don't, it's gonna stimulate their letdown reflex. And we also tell them not to pump their breast. If you pump your breast, it's gonna stimulate your hormonal release, and so you're gonna have more milk that comes in, okay? For your breastfeeding moms, we want them to feed their baby. We want them to do all those things. They can shower normally. But your breastfeeding moms are gonna be at higher risk for developing mastitis. So when I cover complications, I will cover mastitis and what you would see. Okay? Breastfeeding or non-breastfeeding, they can get engorged, which means their boobs are full of milk. So really cool, or like out of the refrigerator, or even the freezer, cabbage leaves help a lot with that, because there's something in the cabbage leaves that helps to relieve some of that engorgement. Complications, I'm gonna come back to and do it last. We'll cover birth control really quickly. So when we cover sexuality later in the semester, we will cover different types of birth control. So all I need you to know right now is that we will go ahead and cover both birth control methods before they go home from the hospital. Breastfeeding is not an accurate form of birth control, so if they are gonna breastfeed, they do not need to use that as their primary source of birth control. So we typically do like a low dose birth control pill for our breastfeeding moms. We can have some other offerings if they want that, like an IUD, or if they want their tubes tied, we can offer that as well. So we do need to know what is their birth control option when they go home. Complications, there's 4 that you need to know. First one is infection. So there's a lot of potential sources for infection in a postpartum mom. So if they're breastfeeding, it can be mastitis. Mastitis is usually gonna present with a very red, angry area on one of their boobs. God forbid they have it bilaterally. It's possible, but it's unlikely. It's usually on the side of their breast, because those are the ducts that don't empty as well. And they are gonna feel like they have the flu. They usually have chills, they're very achy, they run a fever, they just feel like absolute crap. It is an infection, so guess what we do about it? Give them antibiotics. So here's the rule of thumb. If they have mastitis and there is no abscess, they can continue to breastfeed as normal. They need to empty that breast. Otherwise it's gonna get worse, okay? If they're not gonna breastfeed, they need to pump that breast. If there is an abscess, they will pump and dump that breast. So that milk goes away, which is so sad.
Then they cry.
With my last baby, I breastfed, like we cleaned out our freezer, and like she was 2, and there's like 4 little things of breast milk, and I'm like, I didn't get to use it. It's sad, okay? You work really hard for that breast milk, so we wanna use it if we can. So So no abscess, they can go ahead and breastfeed. If there is an abscess, they'll need to pump that breast to clear the duct, but they need to empty the milk away from the baby. So mastitis. You can also have an infection of the episiotomy site. You could have an intrauterine infection. You could also have an infection at a C-section site. So all of those areas need to be assessed to make sure there's no infection. But regardless of the area, what are some common symptoms that we see of infection? Fever, chills, discharge that's purulent in nature from wherever the source of the infection is.
Redness, heat.
What? Redness and heat. And then what lab would elevate?
White blood cell
Their
count.
white blood cell count would elevate. So if they have any of those things, they need to report that to their healthcare provider. That's your infection. Blood clots we've already covered, so DVTs/PEs, prevention of those, that's gonna be one of your complications that we need to educate them about. Let's go ahead and cover hemorrhage. So there are two types of hemorrhage you can have in the postpartum period. Early hemorrhage, which usually happens within the first 24 hours, and it's usually related to uterine atony, where the uterus is not clamping down properly. But you can have a late postpartum hemorrhage that can be seen up to 6 weeks postpartum. If it's a late hemorrhage, it's usually caused by retained parts of the placenta. So there's a little part of the placenta that was left inside. So early within the first 24 hours, usually caused by uterine atony. We treat it with all the things we've already talked about: frontal massage, oxytocin, cytotec, all those things. If it's a late postpartum hemorrhage, then that's gonna occur up to 6 weeks. It usually is because part of the placenta was left inside. Those patients are usually gonna get some of those same medications, but they are gonna require a D&C. So they will come in, they will dilate their cervix, and they will clean out the inside of their uterus to get all of that out, and that should prevent them from having baby. Kinda, yeah. It's called a dilation and curettage, and the curettage is the actual instrument that they use. That's kind of a weird thing. But it goes and it will retrieve any of those things that were left inside that didn't need to be there.
Does that cause infection too?
It can, yeah,
Was that an outpatient?
usually. The last one that we need to talk about is emotional, right? So we talked about those normal phases of taking in, taking hold, letting go. That's the normal stuff. This is gonna be the abnormal stuff. And there's 3 different variants that we need to talk about. So the first one is baby blues. Not exactly expected, but very, very common. So baby blues is gonna be where they have that emotional lability. It's kind of like a little bit of a roller coaster, but they're still getting stuff done. They're still taking care of themselves, they're still taking care of the baby. So that's gonna be the key. So they're emotional, but they're getting up and they're taking care of themselves and the baby. Maybe they're not showering every day, but every other day, they are getting a shower. They are feeding the baby, they're diapering the baby. They're just very emotional. That usually will just kind of subside and get better. We wanna make sure they have resources in place, but that usually gets better. When it becomes a problem is when it gets more severe. So the next step up would be postpartum depression. We screen our moms on admission and in the postpartum period, and they typically get a phone call from someone within the first week after discharge to reevaluate whether or not they're having some postpartum depression issues. With postpartum depression, it's no longer just that you're sad, but you're getting through it. It's you're sad and you're not getting through it, right? So you're not taking care of yourself, you're not taking care of the baby properly, you're just really struggling. Those patients usually require medication. We typically use SSRIs. And you'll cover those when you do your mental health lecture, so I'm gonna cover just surface level for now. So at the postpartum depression level, we are usually gonna medicate those patients. We need to do a lot of education with them and with whoever's gonna be their support people, because we wanna make sure that they have adequate support in the home and that we don't get into a problem where we have postpartum psychosis, which is the most extreme variant. Postpartum psychosis is gonna be when they have a break with reality, they have a psychotic break. They will often present with suicidal ideation with a plan, or they have thoughts of harming the baby or their other children. They often have delusions or hallucinations. And usually, once we get to the point of having postpartum psychosis, that's gonna be an inpatient again. identifying those patients that we know are gonna be at high risk for postpartum depression and aggressively treating them and getting resources in place so that hopefully we never get to this point. So if your mom tells you on admission that she had severe postpartum depression with her previous delivery, then we are probably gonna start them on, medication before they leave the hospital. It's a big deal.
Is it common?
It's pretty common. I would say postpartum depression is a lot more common than people give credit to. I think we have a lot more moms that just struggle through and never get an official diagnosis, but should have gotten. Psychosis is rare. It's not as common. There was one recently in the news, I think it's been about a year and a half ago. It was actually a labor delivery nurse. She had, I think, 2 other children, had a newborn. She had been in care, they had been adjusting her medications. I think they were trying to get her stabilized. They thought she was some better. Her husband went to get food. She killed all of her children and jumped out of the window. She did survive. So once they have that break with reality, you're gonna usually have to be an inpatient admit until you can get them under control and get their symptoms better. The sad reality is, once we identify postpartum depression, it takes about 2 to 4 weeks for that medication to work. So they're gonna be in that limbo, and a lot of times that's gonna be the high-risk time period, and when you start medications until it starts to work, that we really have to be diligent about having support people in place and making sure everything is in order. So you could have a patient that's admitted with postpartum depression inpatient, but you will definitely have inpatient admission if they are considered psychotic, okay? For the safety of them and their newborn.
What if you have like a mom who tells you like, she's a first time mom, she's already struggled with depression during the whole pregnancy and probably like the history of it, would you go ahead and start her on that if she requested it at?
Probably so. So, yes, and they may have even started it before she delivered, depending on the severity. So there's always a risk benefit. Some of your antidepressants are a little bit safer than others, but the reality is we gotta get that mom through this, right? So if there's a small risk of something, they may go ahead and start it in the 3rd trimester when there's less likely to have any issues with like birth defects and that kind of thing, and go ahead and get it in our system so that hopefully we don't get to the point where we're needing additional medication. The scale that we use at our hospital is known as the Edinburgh Depression Scale. You will get some exposure to that in clinical setting and in sim lab, but that is the scale that we use, and it's just a questionnaire and it guides us to say, hey, they're high risk. If they're high risk for suicide before they leave, then they're not discharged. We would keep them there until we can get a mental health consult and some things in place, like a safety plan. All right, any questions about any of those? I'm gonna finish postpartum and then I will be on a quick break. Okay? So let's talk about Keisha. Remember she was the one that had twins? We're not gonna go all the way back through this. I'm just gonna talk about the differences, what you have to add to your care because you had a C-section. So your C-section patients will get antibiotics. They'll get those pre-op antibiotics and those post-delivery antibiotics for about 24 hours. So she will be on antibiotics even if there's no identified infections. This is a prophylactic. She will have a Foley in place because when they do a C-section, they are gonna be completely numb. And so they typically have a Foley. Remember, for your skip protocol, that needs to be discontinued post-op day 1 unless there's a reason to keep it in, which needs to be documented. For your C-section patients, they are typically gonna have a spinal instead of an epidural. We can do it with an epidural, but she was a scheduled C-section, so she'll get a spinal. They will have SEDs in place because they're not gonna be getting up and ambulating, at least not in that immediate period. They will need to have those pump hose in place for the C-section itself and in the postpartum period until they're up and ambulating. And everything else is the same. They're still gonna have rubra, they're still gonna have all the assessments that we do for fundus. You're just gonna add in the fact that they now have an incision to their lower uterine segment, or to that lower abdomen. There may also be a few different medications that you see, so I just wanted to cover these so that we are all on the same page. There are IV forms of both ibuprofen and Tylenol. They're fantastic. IV Tylenol works really, really well in that postpartum period. So you could see those used. Can't really trip you up because I don't use the trade name, so I'm gonna have to say it's IV ibuprofen or IV Tylenol. A lot of times, we don't see this used as much anymore, but there is a medication called Duramorph, which is a long-acting morphine that sometimes is placed in their spinals to give them some long-acting pain relief. If they had duromorph in their spinal, they need to be on a continuous pulse oximetry monitor, because once it's in that space, it's kind of there. We would have to reverse it with like Narcan or something. So it's in that space, so they will be on a continuous pulse oximetry monitor. If they got duromorph, it may also restrict the narcotics they can get in that first 24 hours, because they already have some narcotics on board. Cefazolin is Ancef. That is our drug of choice for our prophylactic and postpartum antibiotic for our C-sections. If they got duromorph, sometimes they can have this weird itching phenomenon where their nose just itches like crazy, but there's no rash. We will usually use Benadryl for that. So if they have that post-duromorph itching, we'll usually give them some IV Benadryl. You don't have to worry about the new vein. Remember Gracie? Aww. We did all the things to try to keep her pregnant, but she did deliver at 33 weeks and 2 days. She did receive some betamethasone and some antibiotics, but baby still remains in the NICU on CPAP, and she's discharged without complication. We're not gonna cover about all the preemie stuff, because that's next semester, so we're just gonna keep on moving. The stuff on the right side we either covered or will cover with a newborn, but I am gonna talk about the terms on the left side, just so that we're all on the same page, and there's not anything that you see on a test or on HESI that gives you a little pause, because you didn't see it. So tell me what the term ectopic pregnancy means.
It goes into.
Yep, it developed outside of where it was supposed to. The most common place is the fallopian tube, but it could be other places, but we're gonna talk about fallopian tubes, because that's where it typically is. So an ectopic pregnancy is a fertilized egg that is implanted in the wrong spot. It is not a viable pregnancy because a tube can never support a growing fetus. So let's talk about your signs and symptoms. Would they have a positive pregnancy test?
Yes.
They would. They often present with bleeding and abdominal pain or shoulder pain. That's the most common complaint that we see. So they would do a pregnancy test, it comes back positive, they do an ultrasound, and all of a sudden there's no baby in the uterus, when they look at the fallopian tube and there is a baby implanted there. There's 2 treatment options for ectopic pregnancy depending on what's going on with the mom and how far along they are. The hopeful, most common one that we see used is gonna be a drug called methotrexate, which is a chemotherapy drug. So by default, chemotherapy drugs kill rapidly reproducing cells, like cancer, but it is a less invasive form of dealing with an ectopic pregnancy. The hope with using the methotrexate is that it will essentially, I hate to say get rid of the fetus, but that's what happens, and help to save that fallopian tube. So if it's caught early, we will usually try methotrexate. They will do some repeat beta HCGs and make sure their levels are dropping, and some close monitoring. The bad thing with ectopics is sometimes we just don't know until it causes that tube to rupture, and at that point they can have a massive hemorrhage, and that would require surgical intervention. So if the tube is ruptured, they will take them for emergency surgery, and they will remove the fallopian tube and control the bleeding. So if you have an ectopic pregnancy that requires surgical intervention, it will affect your fertility, because they're gonna remove that tube. So you're essentially down to just one tube. The last ectopic that we had that I took care of was an emergency case. The tube had ruptured, and there was about 2,000 milliliters of blood in her abdomen when they got her to surgery. Okay, so it is a big deal. If that tube ruptures, it's very vascular, and they can definitely hemorrhage from that. She did, yeah. Young and healthy, always a good thing. Hyperemesis gravidatum, this is gonna be like severe morning sickness, right? This is not just, hey, I'm sick in the morning, this is, hey, I'm sick all day, every day. I'm losing weight, my electrolytes are out of whack. We typically do put these patients on antiemetics, and they will also usually be on that antihistamine B6 kind of mixture. A lot of times your hyperemesis patients will be admitted to the hospital to get their electrolytes back in order. And in severe cases, they may spend the majority of their pregnancy in the hospital receiving either fluids or TPN and lipids. This is more commonly seen in your multiple pregnancies, so if they have twins or triplets, it is more common, but it can be seen with a single pregnancy as well. The other terms are just that, they're terms, and I want you to know what they mean, so that if you saw it in a test question, it would make sense as to what they were actually asking you. So when I'm talking about abortion, I'm talking about miscarriage, okay? We use it as the same term for medical purposes. So these are gonna be, spontaneous abortions or miscarriages, in terms that can be associated with them. A threatened abortion is typically what they will classify as if you have significant bleeding early in pregnancy. Something happened and it is a possibility that you could lose that pregnancy. That becomes a threatened abortion. The next one is gonna be an incomplete abortion, meaning that not all of the products of conception were expelled from the body. So for instance, maybe the fetus was lost, but the placenta was remaining. That would be an incomplete abortion. Everything needs to be able to come out for the uterus to be able to do what it needs to. So if they have an incomplete abortion, they will come in and they will have a DNC. So they'll go in and they'll make sure that all the products of conception are removed. A complete abortion or a complete miscarriage means that everything was expelled. So everything has left the uterus. Missed abortion is a little bit of a weird term, and we would probably call it something different now, but I have seen it come up on some of the HESI questions, so I wanna make sure that you know what it is. So a missed abortion means that the baby has passed away, but the body did not abort the baby, okay? We would typically call that an IUFD, intrauterine fetal death. So missed abortion. With a missed abortion, the fetus has passed away, but the body did not expel it. You're typically gonna see that called an IUFD now, intrauterine fetal death. But you could see it called a missed abortion as well. Alright, the other things we've already talked about, and then the last two we'll cover when we cover newborn. So, it is 5:15. I have y'all to 7:50. That's about 15